All right, so imagine the All Sorts podcast on YouTube, like a garden bursting with ideas, right?
Yeah.
And each video, there's like a new flower opening up full of interesting stuff.
I like that.
And when you hit like, it's like you're giving those ideas sunshine, helping them grow.
Oh, that's good.
And when you share, you're spreading the seeds of, knowledge, letting them take root somewhere new.
Makes sense.
And subscribing. Well, that's like you're tending your own little patch in that garden. So you never miss when something new and cool pops up.
Nice analogy.
We've already got a whole bunch of deep dives out there, like a whole landscape of things to learn about.
It's true.
But the conversation keeps going beyond YouTube, too.
Oh, definitely.
Over on X, Instagram, and Threads. So if you want to join in, keep the curiosity flowing, we'd love to have you.
Absolutely. The more the merrier.
And today, we're diving into something where the body's signals get kind of tricky.
Oh, yeah.
Phantom pain.
Yes. Phantom pain. Really fascinating. And often a really intense experience for people.
So for those not familiar, basically you feel pain in the part of your body that's gone.
Exactly. It's not there anymore. Most people think about it with amputated limbs, but it can happen after other body parts are removed too, like a breast or even your tongue or even internal organs.
Wow, I never thought about it that way.
Yeah.
So, I mean, after an amputation, there's like different things people might feel, right? Not just pain.
You're right, yeah. We need to separate phantom pain from what we call phantom limb sensation.
Okay.
So that's any feeling in that limb that's not pain. Itching, tingling, like it's moving, even a sense that it's still there. And that's super common, actually. Up to 80% of amputees say they've experienced that sometime.
Wow.
And then there's residual limb pain or stump pain. That one comes from the part of the limb that's still there.
So that was more like from the actual wound.
Often, yeah. It can be from the surgery or a neuroma. That's when nerve tissue kind of bunches up after it's been cut.
Sense.
Infection or even the prosthesis not fitting right can cause that too.
Oh, right. So all three can happen together.
Yep. Phantom pain, phantom limb sensation, and residual limb pain all at once in the same person. Makes things complicated.
Definitely. So this isn't new, right? This idea has been around for a while.
Oh, yeah. Goes way back.
Yeah.
Like 1551, Ambroise Paré, a French surgeon, he wrote about his patients feeling pain where limbs USD to be long after surgery. Then, 1871, we get the term phantom limb. From Silas Weir Mitchell, American neurologist, he talked about these thousands of spirit limbs haunting soldiers.
Spirit limbs, that's kind of spooky.
Yeah, it is, isn't it?
So today we're using our sources to figure out, what we know now about phantom pain, what causes it, how it's diagnosed, and what we can do about it.
Exactly. We'll dig into the latest research, the different theories out there, and how well the current treatments actually work. Not always as well as we'd like.
Right. Okay, so first, what's it actually like for someone experiencing this? What are the signs and symptoms?
Well, it usually starts pretty soon after the amputation, like within a week. But the pain itself, that can be all over the place, depends on the person.
Okay.
Could be on and off, lasting seconds or minutes, or it could be constant with these, bursts of worse pain on top of that.
Oof.
And how long it lasts also varies a lot. Some people, it fades with time. Others stays the same or even gets worse.
And the descriptions of the pain, those must be pretty varied too, right?
Oh, yeah. All kinds of descriptions. Shooting pain, like an electric shock.
Sure.
Stabbing. Squeezing, like a tight band. Throbbing. Tingling, burning.
Ugh, I can't even imagine.
And sometimes they feel like that missing limb is stuck in a weird position, like twisted or contorted, really unsettling. And, makes daily life really hard.
Totally. So are there things that make someone more likely to get phantom pain? Like, are there any risk factors we know about?
Well, it can happen after different kinds of loss, surgical amputation, traumatic amputation, even if you're born without the limb.
Oh, that's interesting. So it's not just the physical absence itself.
Right. It suggests something's going on in the central nervous system, the brain.
Think so.
And if you already had chronic pain before, or anxiety, depression, you might be more likely to get phantom pain after an amputation.
Okay.
Some studies say being female, upper limb amputation, pain in the limb before amputation, and pain in the remaining part. Those might be linked. But we need more research on that. Those are still just potential links.
So we're getting into the why now, the pathophysiology, how this actually works in the body. And our sources say the thinking on this has changed over time, right?
Yeah, for a while everyone thought it was mainly from neuromas.
Those nerve bundles.
Yeah, forming at the cut ends of the nerves. They can be really sensitive. But if people born without the limb have phantom pain too, well, neuromas can't be the whole story.
Right, that makes sense.
So the focus shifted to the central nervous system, the brain, the spinal cord.
Okay.
Now the theories are about these messed up nerve pathways and changes throughout the system, from the little nerves to the brain itself. And probably all these theories kind of overlap and work together. It's complex.
Yeah, sounds like it. So starting with the peripheral nervous system, those nerves outside the brain and spine, what's happening there?
Well, the neuromas, they can be a problem. They have tons of these sodium channels.
I vaguely remember those from biology class.
Basically, they're like gates on nerve cells controlling electrical signals.
Right.
More sodium channels, more activity, more signals going haywire.
So like a misfire, sending pain signals when there shouldn't be any.
Yeah, exactly. Especially in those ANC fibers, those carry pain and temperature info. But here's the thing. Sometimes the pain keeps going even when the neuroma isn't T-firing, or when we block the peripheral nerves.
So it's more than just those nerves going crazy then.
Right. The peripheral system might start the pain or change it, but it's not the whole story.
So the spinal cord and brain are key then.
Definitely. In the spinal cord, when a nerve gets injured, lots of stuff happens.
Like what?
Well, some C fibers, those pain fibers, they can degenerate in the dorsal horn. That's a part of the spinal cord.
Okay.
And A fibers, those normally carry touch info, they might start connecting to the places where those C fibers used to be.
Rewiring.
Yep. And substance P, that's a neurotransmitter for pain. It might start being produced by the wrong nerve fibers after an injury.
Oh, so more mixed signals.
Exactly. And all this leads to central sensitization. The spinal cord gets super sensitive, so even a light touch can feel like pain. Plus, levels of some chemicals change. More glutamate, more NMDA receptor activity, those excite things. Less GABA, which normally calms things down.
So it's like the volume's cranked up on pain signals.
Exactly. But even with all this, people with complete spinal cord injury can still have phantom pain. Meaning the brain's involved too. It's not just the spinal cord getting things wrong.
Right. So what's going on in the brain itself? You mentioned brain reorganization earlier.
Yes. We can see this with fMRI. That's functional magnetic resonance imaging. It shows us which parts of the brain are active.
Ooh.
And in most amputees, we see this thing called cortical remapping. The areas in the somatosensory cortex, that's for touch and sensation.
Okay.
And in the motor cortex, which controls movement, the parts that USD to represent the missing limb, they get taken over by neighboring areas.
So like brain real estate changing hands.
Exactly. And that might explain why touching the stump or areas nearby can trigger sensations in the phantom limb.
Wow, that's wild.
And the more remapping there is, the worse the pain tends to be.
So it's connected.
Oh, yeah. And sometimes during an exam, a doctor might find a somatotopic representation of the phantom limb on the chest, stump, or face.
Meaning?
Touching those spots triggers sensations in the missing limb. Like the brain's map is all jumbled.
Seriously? That's crazy.
Yeah. And get this. The further the mouth representation in the brain is shifted towards where the arm USED to be, the worse the phantom pain is.
So the brain keeps adapting even after the injury.
Seems like it. And the pain's tied to those changes.
Fascinating. There's also the neuromatrix theory. What's that about?
So Ronald Melzak came up with this. It's a big picture view of pain. It says there's this network in the brain, the thalamus, cortex, limbic system, all working together to create our sense of our body and ourselves. And each body part has its own neurosignature, a pattern of brain activity that tells us about that part.
Like a fingerprint, almost.
Kinda, yeah. And losing a limb, it messes with that neuromatrix, changes the neurosignature.
So the brain's like, wait, what's going on?
Yeah, and it might interpret those changes as pain, like a glitch in the matrix, literally.
And that could explain phantom pain even without the physical signals from a neuroma, right?
Right. Plus, it suggests phantom pain could be linked to old pain memories getting mixed in. Like, if you had chronic pain before the amputation, it might influence how the brain rewires afterwards.
That makes sense. But it's a theory, right?
Yeah.
Is there evidence for this neuromatrix idea?
Well, sometimes cordotomy doesn't work for phantom pain.
Cordotomy?
It's a procedure that stops pain signals going from the spine to the brain. If the brain's the problem, blocking those signals wouldn't help.
Right.
But the theory has problems too. Like, why doesn't getting rid of phantom sensations always get rid of the pain? And why do some sensations just disappear on their own?
Good points.
Plus, not every amputee gets phantom sensations at all. And it's really hard to test the neural matrix directly. It's so complex.
Yeah, that makes sense. What about body schema and this motor sensory mismatch thing? What's that all about?
So, body schema is our brain's mental model of our body. Even after an amputation, that model still includes the missing part. That's why we have a phantom limb in the first place, mentally.
Makes sense.
But then there's this mismatch. The brain tries to move the phantom limb, but there's no feedback from the body that it actually moved.
Because it's not there.
Exactly. And that mismatch between the motor command and the lack of sensory feedback, that might cause the pain, especially in the parietal and frontal lobes of the brain.
Those are involved in planning and processing movement, right?
Yeah, exactly.
Okay, so with all this going on, how do doctors actually diagnose phantom pain?
Mostly, it's clinical, meaning they listen to the patient describe their symptoms.
No fancy tests.
No blood test or scan can tell you for sure if it's phantom pain. But a physical exam is super important.
Why?
To rule out other causes of pain in that limb. Infection, a neuroma, pressure ulcers, a bad-fitting prosthesis. All that can cause pain too.
Right.
They'll also check your nerves and muscles just in case there's something else going on. Gotta be sure. So managing phantom pain, that's a whole other challenge.
I bet.
Yeah, there's no one-size-fits-all treatment, and the success rate for any single treatment, often less than 30%.
Really?
And sometimes the improvement people feel might just be the placebo effect.
Wow.
So we use a multimodal approach. That means combining different things: meds, physical therapy, psychological support.
Okay.
Let's start with meds, often used alone or with other treatments. And sometimes combining therapies means you can lower the dose of the meds.
Makes sense. Less side effects, hopefully.
Exactly. One common type is tricyclic antidepressants. Amitriptyline, nortriptyline. Those have helped with other neuropathic pain.
That's pain from nerve damage, right?
Yep. They work in a few ways. Blocking calcium and sodium channels, acting on NMDA receptors, messing with neurotransmitter reuptake.
Complicated stuff.
Yeah, but basically, they change how pain signals are sent and received. For phantom limb pain specifically, the results have been kind of mixed.
So might work, might not.
Right. And they can cause drowsiness, dry mouth, blurred vision, those anticholinergic effects.
Not fun. What about other antidepressants?
Duloxetine, that's a SNRI. It shows promise for other neuropathic pain. Not much data specifically on phantom limb pain yet.
Okay.
But some individual cases suggest it might help. SSRIs, those are less effective for this kind of pain usually.
What about just numbing the area? Like with local anesthetics?
Tried that. Bupivacaine injections, those have helped short-term in some studies. But lidocaine infusions, those haven't really worked.
Maybe because lidocaine mostly works on those peripheral nerves, right? And we know it's more than just that.
Exactly. It's not getting to the central nervous system where a lot of the action is.
Makes sense. How about those meds, the sodium channel blockers and anticonvulsants? Those are for nerve pain, right?
Yep, gabapentin, pregabalin. They bind to calcium channels. For phantom limb pain, the evidence is kind of shaky. Some studies say they work, some say they don't.
Conflicting results.
Right. Carbamazepine and lamotrigine, those are sometimes used if the first options fail.
So, kind of a backup plan. Yeah. What about stronger stuff? Like opioids?
Those can be effective for this kind of pain, yeah. Oxycodone, methadone, morphine, levorphanol.
But those have a lot of side effects, right?
More than some other meds, yeah. Tramadol, that's a weaker opioid, but it also affects serotonin and norepinephrine.
Oh, so kind of like a combo.
Yeah, and it's shown some promise for neuropathic pain in general.
Interesting. Anything else being researched for phantom pain?
Oh, yeah. NMDA receptor antagonists, ketamine, for example, that's shown some potential.
Oh, so.
It might help reverse central sensitization, that overexcitability in the spinal cord we talked about. Memantine, another one that's had mixed results. Maybe it's better if you start it right after the amputation.
Yeah.
Calcitonin, that's a hormone, seemed to help in one study, but only early on, not for long-term pain. And beta blockers and calcium channel blockers, we're not really sure if those work for this.
So lots of options, but finding the right one is tough.
Yeah, trial and error for each person, unfortunately. But it's not just about meds. What about non-pharmacological approaches?
Right, the stuff that isn't NIG medication. Let's hear it.
Well, there's RTMS, repetitive transcranial magnetic stimulation.
What's that?
Basically, it uses magnets to stimulate specific brain areas. For neuropathic pain in general, it's shown some temporary relief.
Okay.
For phantom limb pain, the results are mixed. Some studies say no effect, others say it reduces pain, especially when you stimulate the motor cortex on the opposite side of the brain from the amputation.
Interesting. We need more research on that one.
Definitely. Then there's mirror therapy. That one gets talked about a lot.
How's that work?
You put a mirror between your legs with your intact limb in front of it. The reflection makes it look like your missing limb is there and moving.
Oh, I've seen videos of that.
It's thought to resolve the conflict between what you see and what your body feels, or doesn't feel in this case.
Clever. Does it actually help?
It's debated. Some studies say yes, some say no. Reviews suggest it might shorten the pain and make it less intense, and it might help reverse that bad brain rewiring we talked about.
That's pretty cool. Any other therapies that try to retrain the brain?
Yeah, graded motor imagery. Originally for complex regional pain syndrome, but now used for phantom pain too.
What's involved?
Basically, you gradually get your brain used to the idea of your missing limb again. First, you just look at pictures of limbs left and right. Then you imagine moving the phantom limb. And eventually, you might move your intact limb while looking at its reflection, like in mirror therapy.
Interesting.
And studies show it can actually reduce phantom pain.
Neat. What about tech stuff, like virtual reality?
Oh yeah, that's a newer area, and it's promising. It's called motor execution with biofeedback in VR. Basically, you wear a VR headset and see a virtual version of your missing limb.
Whoa.
And you try to move that virtual limb in the VR world. The idea is to match the visual feedback with what your brain is trying to do, and that might reduce the pain.
That's amazing.
Yeah, we've seen some good case reports, but we need bigger studies to be sure it really works.
Makes sense.
Yeah.
What about mental imagery, just picturing the movement in your head?
That's been studied too, and fMRI shows it might actually reduce pain. It seems to change the brain activity in amputees with pain.
Huh. Any other more traditional or alternative therapies?
Well, there's biofeedback, like temperature biofeedback. That's sometimes used for burning pain, but the evidence is kind of weak.
Ugh.
We've had some case reports where visual feedback helped, and some people say acupuncture is good. But don't forget about psychology too. Just explaining what phantom pain is, reassuring people, that can help a lot.
Right, it makes sense.
Hypnosis, psychotherapy, cognitive behavioral therapy, those can all be helpful for coping with the distress.
So it's really about addressing the whole person. What about extreme cases, like when nothing else works? Are there any surgeries?
Yeah, for those really tough cases, we might consider things like spinal cord stimulation, deep brain stimulation, or motor cortex stimulation.
Oh, those sound intense.
They are. They involve implanting electrodes to change nerve activity. But they don't always work, and the benefit can fade over time.
So really a last resort.
Pretty much. We also sometimes try DREZ lesions. That's a procedure on the spinal cord. But again, mixed results. There's even been one case report where electroconvulsive therapy, ECT, helped someone with phantom pain.
Wow.
Yeah, but we don't really know why it worked.
Still a lot of mystery there.
For sure. And it's important to remember that prosthesis training is important too.
Oh, right. Getting used to the prosthetic limb.
Yep. It helps with rehab, and it can actually reduce residual limb pain, which sometimes contributes to the overall pain experience.
So it's all connected.
It is. Phantom pain is such a complex problem, and we still need better treatment.
Absolutely. We've learned so much about it, but there's still so much we don't know.
True. And the best approach right now usually involves a whole team. Doctors, pharmacists, physical therapists, psychologists, all working together.
Makes sense. This has been a truly mind-blowing deep dive. It really makes you think about how the brain creates our experience of our own bodies. So here's something for you to ponder, dear listener. If our brains are so adaptable, what other things in our lives, things we think are fixed, could we actually retrain and rewire?
That's a great question. Really gets you thinking.
And speaking of retraining and rewiring, let's talk about you amazing folks on YouTube. Imagine the All Sorts podcast as a vast ocean of knowledge. Every like, every share, every subscribe, those are like currents, pushing that knowledge further, making it stronger. Your engagement is what keeps this ship sailing.
Hey, you're here.
And don't forget all the other deep dives we've done. They're out there waiting to be explored. And the conversation keeps going on X, Instagram, and Threads too. Every comment, every follow, it all adds to the map of what we know together.
So true. Thanks for joining us on this incredible journey into phantom pain. It's been a wild ride.
Absolutely. And until next time, stay curious.